Thank you very much. So good afternoon, everyone, and welcome to what is now our fourth public stakeholder meeting of the House Bill 413 Interagency Working Group. I'm Kathleen Borain. I serve as the Maryland Insurance Commissioner, and I want to thank everyone for joining us today for what will be our final public meeting before we complete and expose the initial draft of the report for comment. So after today, our next step will be to finalize our initial draft, which we will send out, and then we will reconvene in public session to talk through what the provisions of the initial report. As we've done for previous stakeholder meetings, I'd like to start this meeting off with just a little bit of background information if there's some newbies here today. In 2022, the Maryland General Assembly passed House Bill 413. This legislation required the Maryland Insurance Administration, in consultation with the Maryland Health Benefit Exchange and the Maryland Healthcare Commission, to report to the Governor and the General Assembly on the impact of the state reinsurance program. And that report is due on December 1st of this year. In preparing this report, the MIA is required to consider several factors. That includes the necessary level of funding for the program, sources of funding for the program, market reforms needed to provide affordable health coverage in the individual market, and the design of the program and program parameters in light of existing state and federal market reforms. Now, to complete this report, the MIA formed an interagency work group with representatives from MHBE, MHCC, and the Maryland Department of Health. Representatives of these agencies have been meeting regularly since February to discuss the topics required to be included. However, stakeholder input is critical to the development of our report, and for that reason, our work group has scheduled several public stakeholder meetings, today being the last of which before the report itself is drafted and there's an initial review. So during our first meeting on May 11th, we discussed Maryland's reinsurance program's design, size, and parameters. During the second meeting on May 25th, we focused more on market reforms beyond reinsurance that have been implemented or considered in Maryland and other states, and the impacts that those other reform measures have or could have on our market. Stakeholder feedback provided during these first two meetings helped inform the actuarial modeling that was presented and discussed during our third meeting on August 8th. Now, during our third meeting, we were very aware that there was an enormous amount of very dense and very detailed information that was provided with respect to the modeling. And there were some adjustments that were being made to some of the models really literally up until the time of the meeting. So what we wanted to do was give people a fulsome amount of time to be able to look at the final presentations, the final information and the actuarial models, and then come back together to allow people to ask questions that they didn't get the chance to ask or frankly even formulate in our last meeting. So our goal for today is really very simple. It's to provide a forum for you to offer feedback on the actuarial modeling results and the funding of the reinsurance program, and to ask questions that you might have about any of the materials and information that has been presented so far. While the conversation will be guided by my team, and by my team, I mean really the entire interagency working group based on the agenda that we shared in advance, this meeting is really your opportunity to share your thoughts and your views and to ask your questions. So for anyone who hasn't joined us previously, not familiar with our protocol, as we make through the agenda, our way through the agenda, stakeholders are invited to raise their hands with questions, to type questions into the chat function. If you want to be brought over to the panel to be able to be on camera or for us to hear you, just please let us know, and as we'll be happy to do that. To ensure excellent sound quality throughout today's meeting, we ask that you please stay on mute unless you're speaking. And if you have any technical difficulties, please reach out to Suzanne Forno via direct message or email. Her email is in the chat room. So before we get started, I'll just take a minute. I think we all know each other pretty well by now, but just very briefly, in terms of the membership of the HB 413 working group, I will just note that present with us today are our chief from the MIA, are our chief actuary, Brad Boban, our senior actuary, Adam Zimmerman, our Director of Legislative and Regulatory Policy, Jamie Sexton, and Suzanne Forno, as I indicated, is available to assist with any technical issues that arise. So with that, let me just take a minute to let the folks from the Maryland Health Benefit Exchange and then the Maryland Healthcare Commission and then other government representatives, including the representatives of the Department of Health, introduce themselves. So why don't we start, if we could, with Michelle Eberly, who's the Executive Director of the Exchange.
Good morning, Commissioner Rain, and thank you again for holding this public hearing. I am the Executive Director for the Maryland Health Benefit Exchange, and with me today I have Johanna Fabian Marks, who's our Director of Policy and Plan Management, Amelia Marcus, and Becca Lane, both of our health policy analysts for the Exchange.
And I know we have some folks here from the Maryland Healthcare Commission, if you'd like to introduce yourselves.
Sure. Good morning. My name is Kenneth Stratman, the Director of Analysis and Information System. I had my colleague here, Tracy DeShields. I'm very, very happy to be here. This is a worthy cause as we try to nail down, and have all of these questions and your input, from stakeholders for this very, very important effort. Thanks.
Thank you. Any other state agencies that were able to join us today? And then I would also recognize we have here Delegate Cullison is with us today. So welcome to you. Patrick Carlson, who staffs the Senate Finance Committee, is here today. If I have missed any of our other legislators, I apologize. Please just give a shout. But with that, I think that we are probably ready to jump right into our agenda. And I'll turn it over to Brad Boban, our Chief Actuary, to lead today's session.
Thank you, Commissioner. So as the Commissioner said, we don't have anything new to present, but I want this to be an opportunity for you to ask any questions or make any comments on what was presented last time. So I'm just going to present the slideshow that we had at meeting number 3. Give me 1 second. Can everybody see the slideshow that I'm looking at?
Yeah.
All right, great. So I was just going to go through the slides and ask for any questions unless anybody wanted to jump in and jump to a certain section. This first slide here is a summary of the current waiver. It's not really a projection, except for the
Brad,
yes?
I'm sorry, but Delegate Colson's hand is up. So.
Oh, excuse me. Sorry, I missed that.
Okay, that's right. I know it's hard to see.
Yeah. Thank you, Commissioner. Thank you, Brad. And before you got too deep into the weeds, I just was wondering, I know that you gave people the opportunity to ask to send questions to you, and I wondered if that happened and if you're going to be able to summarize any responses that you gave to those, or are you just engaging in discussions and questions now about this?
Jamie, correct me if I'm wrong, but we haven't received any questions in advance. We received a couple comments, and we were not planning to go through those comments specifically, but we had not received any questions in advance.
That's fair. Okay, great. Thank you. Thanks. So now I'll let you get back into it. Thank you.
Yeah, no problem. So this is just a summary of the current waiver. Every number on here is final except the 2023 reinsurance costs. Any questions about the current waiver and this current financial projection? All right, great. So then we had 2 sets of waiver projections. The big variable is whether or not ARPA gets extended in 2026. Under current federal legislation, the enhanced subsidies that were originally under ARPA and got extended under the Inflation Reduction Act and December 31st, 2025. So this first projection shows the projection if ARPA expires. The key point that I will note on this one is that when you look at the ongoing funding levels, you know, in the middle of this slide, that starting in 2026 under this scenario, the ongoing state assessment is insufficient to cover the state share of reinsurance on an ongoing basis. But we have $443 million in balance built up as of the end of 2026. And so, you know, there is no short-term issues with the reinsurance program under this ARPA scenario. But, you know, on longer term, and if we are going to get another extension after this, you know, under this scenario, you know, we are running a shortfall on an annual basis, and eventually those funds are going to run out. But we will end the next waiver with a projected 336 million, even under this scenario, because, you know, we're starting in a good enough position from the first waiver. And then this next slide was the projection if ARPA gets extended. And in this scenario, the projections are fundamentally different in that it is projected that the ongoing cost of the state portion of reinsurance will be less than the assessment. And so in this scenario, the state balance continues to grow. So if this ARPA gets extended, you know, this says that the 1% is sufficient to cover the state portion of reinsurance, and perhaps there is more funds to do something else. But, you know, right now we do not know whether ARPA is going to be extended. So that's why we're running these two sets of scenarios. So did anybody have any questions or comments about these? One last thing I want to note is that embedded in both sets of these scenarios is the assumption that we're going to be increasing the attachment point by $1,000 per year. That's what was filed in the approved waiver extension. That's different than the first waiver. The first waiver, we had $20,000 attachment point for the first 3 years. For this year, the attachment point was lowered to 18,500 because of the uncertainty about ARPA when the rates were being set. And then for 2024, it is going back up to 20,000. But in this projection, it starts out in 2025 at 20,000 and then goes up 1,000 per year. Yes, Delegate Collison.
Thank you for your patience, Brad. So it goes up 100,000 per year. I mean, 1,000, not 100,000 per year. For how long? Or is that there's no limit to that? That's my first question. And my second question is, have we heard from the insurance carriers any feedback on that attachment point? The increases.
Yeah, the $1,000 increase per year is through the entire waiver period. So each year, you know, it would start out at the 20,000 and then go up each year and end at 24,000. And you know, as a reminder, that was done to control the rate of increase of reinsurance costs. That if you don't increase the attachment point, then the total cost is going to increase at a rate higher than trend, but by increasing the attachment point, it's kind of keeping pace with trend. And so the growth in reinsurance costs in these scenarios are lower than what we experienced in the first waiver period. And to date, I've not received any comments from the carriers about the plan to raise the attachment point, either pro or you know, in favor.
Well, we do have a comment from Allison that KP thinks that this is a very reasonable approach, and Matt has his hand raised. So
thank you, Commissioner. I think I had relayed to Jamie after the first meeting, the carriers are aligned in the support of the raising of the attachment point. Just so FYI, Delegate Collison.
Thank you, Matt. I appreciate it.
So any other questions about these what I'm going to call the two core reinsurance projections?
Matt, do you still have a question, or do you want to, your hand is still up? Okay, thanks.
Sorry, I'm in a hallway in Nashville.
Thank you.
So moving on to the other things that we modeled with respect to reinsurance itself was the possibility of changing some of the parameters. This is the history that I just talked through. We modeled revenue neutral reinsurance parameter changes. In all of these scenarios, the state would be expected to cover the same percent of claims. And this is all relative to the current parameters of $20,000 attachment point, 80% coinsurance, $250,000 cap. So we modeled these different scenarios. And in general, I would say I would summarize this modeling as there's not very much room to change our attachment point in a revenue neutral manner. You know, the cap would have to be raised to a very high level. You know, some states do use caps this high, but you know, there's limited room to move in a revenue neutral manner. And so we moved on to model things if they were not revenue neutral, and if we let them have a premium impact. And so if we raise the attachment point to 25,000 from the 20,000, you know, that would be about a +4% premium impact, and it would lower the percent of claims that the state covers. And we modeled the premium impacts for different levels of attachment points. And as well as changing the coinsurance. And then finally, we put together 2 additional modeling scenarios. In this scenario here, instead of raising the attachment point by $1,000 per year, we raised the attachment point by $2,500 per year. And in this scenario, this is the ARPA, where our state funding is not enough to cover the reinsurance cost. It's still not quite enough in this scenario, raising the attachment point at a faster pace. But the yearly deficit is less, and therefore we have a ending balance that is higher than in the core scenario, where we raise it $1,000 per year as planned. And then we also modeled an impact of raising it $5,000 per year. And on this one, you know, the reinsurance dollars on an absolute value start falling in this scenario, because now we're raising the attachment point much faster than claims trend. And in this scenario, we have brought down the state cost enough that the 1% assessment on an ongoing basis is sufficient. And you can see the end of year state balance in that bottom row growing in this scenario. So, you know, this was to explore the range of options of what we could do with the reinsurance program. I do not believe we've gotten any comments supporting explicitly any of these 2 alternative options. You know, the offset of this is the rate pressure. You know, the $5,000 per year brings the attachment point from $20,000 at the beginning to $40,000 at the end. And if you go back to this slide here, that is a 16% premium impact over that waiver period. So that is 16% upward pressure on individual premiums if we were to make that change. And so, you know, that's kind of the trade-off there. You are having a more solvent program, but you are having an adverse impact to the premiums. And so I guess at this point, I would say any questions or comments on any of these modeling scenarios about alternative reinsurance parameters, either the revenue neutral ones or these ones that reduce the size of the program and you know, put the upward pressure on the individual market. Yes, Allison.
Just to make sure I'm following this, if we look at example 4 there, this would essentially mean if the additional objective was to lower premiums by 30%, then this would only be doing that by like 8% because we've lost the 22% that's that we would be losing by raising these parameters or changing these parameters. Is that a reasonable way to think about that?
No, it's not additive. If you're 30% off and then you multiply that by 1.22, you end up at 0.85. So we would end up with half of the impact basically of what we're having now. So it's not, the 22 doesn't get subtracted by the 30. It needs to be multiplicative.
Okay, got
That
it.
makes
Thanks.
sense.
Yeah, totally.
And we modeled those scenarios over time. I mean, we any abrupt movement to the attachment point is going to have a bad impact, and so that's why we did the modeling of smaller amounts over time. But the intent was that this scenario 10 gets you to the 40,000 at the end. And this gets you to the 30,000 at the end. So it's equivalent to options 2 and 3 here, but spread out over time. So there's not that one year 9 or 16% jump in premium. So that is spread out over the 4 years of the increases.
Diana?
Hi all. So my apologies if this has been addressed in one of the previous meetings. I was unable to attend. But have we discussed if we raise the attachment point, how many lives would maybe fall out of the pool? Has there been any discussion or projection about that?
Yes, that is part of these projections. So if I go back to the core scenario 2, ARPA expires. So when we're raising the attachment point by $1,000, they're projecting the average enrollment at the end of 2028 is going to be 216,000. That's lower than today's, but that's because ARPA is going to expire and we're projecting that it's going to cause enrollment losses. And then if I go to slide 9, where we raise it by 2,500 per year, 214,000. So they're estimating about a 2,000 adverse impact to enrollment if we did that. And then if we go to the 5,000, their enrollment impact is a little under 212,000. So part of this enrollment projection is their enrollment projections are detailed by income, and all of these rate increases would really impact the unsubsidized members. The subsidized members get insulated from this because of the subsidy. So they take that into account. So the enrollment losses might be smaller than you intuitively expect, but that's because 65-70% of people get subsidies and get shielded from those increases. But yeah, the enrollment losses are being modeled here.
Got it. Thank you.
All right, any other questions on reinsurance in general before I move on to the subsidy part of these modeling? Yes, Delegate Collison.
It's not a question, Brad, but it's a comment. And before you go into the next phase, I wanted to just put this out there. I really truly appreciate all the work that you've put into this, and it's tremendous. And while the numbers boggle my head, this has been helpful in terms of understanding what the impact is of various factors. But I want to say, we did this exercise because we wanted to be able to look at what the program, what would happen to the program under these different scenarios. And if how quickly we would be depleting our state balance, with and without ARPA. Two things that I have to deal with when I'm defending the reinsurance program is the cost of premiums. So I have to look at things, that I would, if I suggested that we do something that significantly raised premiums, I'd have a hard time defending that on the floor, especially now in this economic climate. So just that's really hard. And the other thing is, if we continue to have a balance, although it is clearly diminishing, then it feels to me like we can stay where we are through this current waiver with the knowledge that we have time. We have time to watch the program to see if there are any unexpected changes in it, and also to put other things in place that could potentially decrease the need for the reinsurance program. The reinsurance program was never intended to be, permanent forever. I mean, we wanted to make sure that we had it in place to make sure that we could maintain our premium levels or even sustain them, and have only reasonable increases. But we're really looking for a way to make it, to find out how we don't need that program, and that relates to utilization and it relates to total enrollment of the state. So I think, I know that there's a lot of interest and willingness to look at all of the different things that could decrease the need for the reinsurance program. I am saying absolutely I want to keep it now, and I suspect in 5 years I'll want to keep it again, but we have that 5 years to think about it. So my point is, since I've rambled on here a bit, is as I'm feeling comfortable with the 1%, with the all the factors staying as they are, with the increase in attachment points, and knowing that we have time to watch and look at other programs that could positively impact the reinsurance program. So that's where my head is right now, and I wanted to make sure that you knew that. So thank you.
Thank you for the feedback. And yeah, I agree. The reinsurance program is in a healthy state with the current 1%. I'd say with the caveat that the funds are not redirected to other purposes. And so, there are other things that people want to do. And in the past, the reinsurance funds have been redirected. That's part of that $35 million of other state outflows. But I absolutely agree that if the reinsurance funds stay with the reinsurance program, we're in pretty good shape right now.
So Brad, you're singing my song. And I am saying that in every meeting where reinsurance comes up. Now, it is, was not intended to fund a lot of different programs. So, I agree with you 100%.
Great. All right. So with that being said, I'm going to move on to the subsidy portion of this modeling. So the first set of subsidies we modeled was the potential to offset an ARPA expiration if the feds allow that to happen. So this slide was just an example of what would happen to the premiums when and if ARPA is allowed to expire. This is by FPL, federal poverty level. This shows the premium that somebody would pay if they select the benchmark plan, the second lowest cost silver plan. The subsidies are based upon. So under ARPA at 150%, you pay 0. Under the original ACA, you would pay 65. And so, you can go down the columns and you can see, that on a percentage basis, it's a super high percentage for the lowest incomes. Even on a dollar basis, it is a pretty large dollar increase. And, if this is to happen, like I said, 65 to 70% of the pool gets these subsidies. And so, the adverse impact to enrollment is expected to be a lot larger than what was shown for allowing the attachment point to rise. I don't have those enrollment numbers as part of this. In the past, we have modeled it. No, I guess we do have it as part of it. You know, the ARPA versus no ARPA scenarios. So I mean, if we go back to the ARPA projection, 216,000 at the end of the waiver if ARPA expires versus 234,000. So it's a pretty big expected enrollment loss if this happens. So Lewis and Ellis modeled the cost to offset the impact of ARPA expiring. This is the cost to exactly replace ARPA as it currently exists. So you'll see it goes over 400% because part of what ARPA did was remove the cap on subsidies. So anybody that has to pay more than 8.5% of their household income for that benchmark plan is now eligible for a subsidy. On a practical basis, that only really happens for older people because younger people's premiums are lower than that. So you can see a lot of money in that 400% bucket is all concentrated in those older cells. So this showed that it would cost $149 million in 2026, increasing on an annual basis to replace the federal ARPA subsidies, in whole and in their entirety. And then this next scenario shows, what would happen if we used the state reinsurance money to try to fund this subsidy. And the results are, we wouldn't even quite have enough money to do it. It would completely exhaust all of the funds that we've built up to this point, and we would be $48 million short. So, if ARPA expires, the 1% is not enough to replace it. We could trim and not quite replace it perfectly, and make tweaks to it and lower the value, but it would still cost way more than the 1% annual assessment is bringing in. So we have this uncertainty hanging over the state for if the federal government removes these enhanced subsidies, what's going to happen. But this was the estimated impact to try to keep that enrollment loss from happening. So any questions or comments about this component of the modeling that was done? All right, not seeing any hands. I will move on to the next section. So the next section of the study we did was on the undocumented population. And this scenario is where things started to get really complicated with lots of different scenarios. There is a different study being done that is due sooner than House Bill 413, and we are coordinating with them and making sure our assumptions are consistent. A big part of the uncertainty with this is the uptake assumptions. For all the modeling that has been done on these subsidies, the per member per month cost is a much firmer estimate than these enrollment estimates. And so that's why we have these uptake assumptions. So on the low side, this presentation is showing 8% on the low. That is being adjusted as we speak. It's going to be 13%, I think, Johanna, correct me if I'm wrong, in the revised scenario to be more aligned with what is being assumed on the Medicaid side. We are consistently assuming that the Medicaid uptake will be higher than the QHP uptake because it's easier to enroll in Medicaid. Medicaid can be retroactive after a claim occurs, while QHP enrollment cannot. So this modeling here just shows the QHP portion, what it would cost to cover this population under in the exchange through plans. So going on to the actual numbers, so this first part shows the population that is over 138% FPLs. So there's not parallel modeling going on for this population with Medicaid. And so as far as the numbers on this page go, the top section breaks the cost into the three components that were modeled. On the left is the direct cost of a subsidy that would replicate the federal subsidy. And the low, midpoint, and high are the uptake assumptions, the enrollment assumptions. We have an ARPA scenario and a no ARPA scenario. The ARPA scenario is more expensive because the ARPA subsidies are more generous to be replicated. And so the no ARPA scenario is cheaper. So that goes opposite of what happens on the reinsurance side. If ARPA expires, this type of subsidy would be cheaper. If ARPA gets extended, this type of subsidy will be more expensive. So there's the direct cost of the subsidy, but then there is also the reinsurance cost. Since we are running the reinsurance program, and if these people join the single risk pool, their claims would be eligible for reinsurance. But since there are no federal subsidies and there are no federal savings being generated, there will not be any offset. So we need to take that extra reinsurance cost into account. And that's the second section. And then the third section on the top is the CSR cost. And so the idea here is that right now there are two sets of subsidies for people to purchase on the exchange that are under 250% FPL. There's the premium tax credit, which lowers the premium, and there is the embedded cost sharing reduction subsidy that makes the silver plan something that is actually usable and accessible for that population. A normal silver plan for an unsubsidized person would have a deductible of $3,500 to $5,000. A CSR silver plan for the low income population would have a deductible $0 to $1,000. And so we've modeled the cost of providing parallel cost sharing reduction subsidies as well. So all of those costs have been added together, and the bottom left of this slide says the total cost all in. So if on the low uptake scenario, if ARPA doesn't get extended, it's projected to cost $27 million total to cover these QHP eligible adults. On the high uptake scenario with ARPA getting extended, it's $229 million. So that is a factor of 10 between that low and high. And then on the right, you can see the uptake assumptions. So that low no ARPA assumption is assuming that 4,000 people will actually utilize this coverage, whereas the high ARPA scenario is projecting 32,000 people. So that's obviously a huge amount of uncertainty. But like I said, most of that uncertainty is driven by the enrollment portion. And so we did the same thing for the Medicaid / CHIP eligible population. And so this is where the parallel calculation is being done to model how much would it cost to cover this population under Medicaid or CHIP, just funded by state funds only, versus how much it would cost to cover them via this. So we are still tweaking the assumptions to be consistent. So these will not be the final drafts, but this is the initial set of modeling that was done. Similar kind of thing on the top. It was divided into 3 buckets of cost: the premium reductions, the cost sharing subsidy reductions, and the reinsurance costs. And then the totals are on the bottom, and the enrollment impact. So the enrollment wise, you can see that these buckets are in aggregate kind of similar in size. The highest scenario of this over 138% FPL population is a little bit higher, but these are both pretty significant populations. And then in Excel, we gave much more detail on all of this modeling with age and FPL buckets, and you can see all that detailed modeling that went into these roll-ups. So that's a high level summary of what was modeled for this undocumented population. And then, we talked about a phased approach, and every other state that's done this, they've not done it wholesale to all ages. That they've, picked certain ages to prioritize. Children are a general prioritized age. Age 65 is also a typical one to prioritize. And then a typical approach is to fill in the gaps from there. And then this is the kind of detail that was provided in the slides. This was just for one of these scenarios. But like I said, you could see the age and FPL assumptions. So, you can see for each age bucket and FPL bucket, how many people we assumed would come into the market, the annual cost for different components. You can see how that varies by age, and that all gets rolled up to those grand totals. So I don't know if anybody had any questions about any of this modeling or any comments on it. But before I move on, I'll open it up. All right, not seeing any hands. I'll move on to the next part of the modeling, which was for supplemental state subsidies. These subsidies are for those who are already eligible for state subsidies. They're analogous to the young adult subsidy that we are currently doing for those under the age of 35. But this is being modeled for all ages. One change that was made from the young adult subsidy is to change it to a flat PMPM versus the current young adult structure, which is based on a percent of income and makes it regressive, where higher incomes get larger subsidies. So this was modeled as a flat PMPM subsidy, with the exception that nobody can get a premium lower than zero. So if the federal subsidy already brings your premium below this subsidy level, you're capped at whatever it takes to get you to zero. So as these subsidy amounts get higher, a larger and larger percent don't actually get the full amount. But these were modeled as a flat PMPM with that exception. And then once again, we did the ARPA and the no ARPA set of scenarios. And so, this page has a summary of the total cost. The $40 PMPM on the left approximates what the current young adult subsidy is giving on average. And so, that was chosen as a relatively low level of subsidy. And then we chose these other levels based on, looking at the other states who give subsidies for this population, what kind of level they give. The 125 at the top is kind of, the richest level of state subsidy. These are all grand totals for all ages. Once again, we did this modeling at a detailed by age and FPL, so that if, it was desired to give this subsidy to a more limited population, that we would have that detail here. And so, once again, this PowerPoint just pulled one example, but the Excel files that we also put on the website have all of the detail for all of the different supplemental state subsidy scenarios. And then in general, for the mathy people out there, you can use interpolation to get numbers in between, and it's a pretty good estimate. It's pretty linear, this particular set of modelings. So if you want to estimate a subsidy amount between these values, interpolate or extrapolate should be fine for that. So Delegate Collison, I see you have a question.
Yes, thank you, Brad. I just want to make sure that I'm understanding. And in these slides 23 and 24, that would be 100% of the people who are eligible. Is that what where these numbers come from? It's
Yes.
not it's not an estimated enrollment. It's estimated as far as we know this many people are uninsured and undocumented. Is that where your numbers are coming from?
So this is not for the undocumented. So
Oh,
the
okay.
undocumented was the previous section. This is a supplemental subsidy for those who are already eligible for the federal subsidy.
Oh, like
and
a young adult. Okay.
there is some enrollment uptake assumed in here. It's mainly people that are already in the market, just like the young adult subsidy. I mean, everybody that's in the market today would be eligible for these supplemental state subsidies, but there is also, you know, enrollment uptake assumed. I do not have those numbers in this slideshow, but it is in the actuarial modeling. The higher the subsidy, the more enrollment uptake they assume. So you know, that is embedded in these grand totals, but most of the dollars are going to the existing population and just lowering existing rates.
Premiums. Okay. Thank you. I'm sorry I was confused, but that's very helpful. Thank you, Brad.
All right. Any other questions? All right, not seeing any hands. Then I'm going to move on to state cost sharing reduction subsidies. So we modeled supplemental state cost sharing reduction subsidies parallel to how New Mexico is doing these. And so the subsidies are being modeled to be on silver for those under 200% FPL and on the gold medal level for those over 200% FPL. And so in this set of modeling scenarios, you know, we have modeled bringing the actuarial value to various higher target levels, and how much that would cost. And so, you know, this chart, you know, has a lot going on it, but you know, it's segmented by FPL. So the top section is 0 to 150. You know, the federal AV for this population is 94%. So that means on average, the insurance company should be covering 94% of claims. Member cost share should be on average 6% of claims. In practice, you know, a lot of 94% CSR plans have $0 deductibles, but you can still have a modest deductible of like $1,000. You can still have, you know, decently high copays. So, you know, other states have added supplemental subsidies on top of the federal one. And so we've modeled bringing this population to 95% like Massachusetts does for 100 to 150. We've modeled bringing them to 97%. We've modeled bringing them to 99%, which is what New Mexico does. And we've modeled bringing them all the way to 100% with no cost sharing, which is what Connecticut does and what Massachusetts does for under 100%. So, you know, we have the PM cost, the per member per month cost estimates for each of those, the projected number of enrollees. Here, we are not projecting enrollment changes. There's not enough data to really say how these CSR changes would impact enrollment. You know, no state's really done them without premium subsidies as well, and it's very difficult to try to disentangle how many people enroll because of premium subsidies and how many people enroll because of CSR subsidies. That's not to say there wouldn't be any impact and this wouldn't entice anybody else into the market, but we don't have any data to make those assumptions. So we have the cost instead of enrollees, and then we have the total cost that it would cost for this cost share subsidy. And so it was modeled for each of these income levels. You know, 150 to 200 currently is at 87% AV, and we've modeled to bring them up to 90 to 100%. And then, like I said, that higher metal level, you know, we are modeling it on gold, and that rationale is based on it being the cheapest way for the state to do this, basically. And it makes more sense to do so than on silver. So this 200 to 250% FPL, they're technically eligible for a small cost sharing reduction subsidy on silver from the feds to bring the silver AV to 74%. But that's not very good and hardly lowers the deductible at all. A base plan is 70%. And so, you know, in this scenario, all of these people would be foregoing that small federal cost sharing reduction subsidy and getting a better one on gold from the state. And then that 250 to 300% population doesn't get any cost sharing reduction subsidy now. Under the original ACA, they were intended to get a cost sharing reduction subsidy, but the math did not work out to allow them to do so. So CMS could not actually do that. And so once again, you know, these other states that are doing these subsidies generally bring it up to that 300% level. So all of these would serve to lower those deductibles, and you know, that those higher levels would, you know, end up with deductibles in the 0 to 1,000 range, and you know, the people at the lowest incomes would end up with $0 deductibles and very low copays. You know, that 99% scenario is going to be single-digit copays on services. So you know, there's a lot of dense material here. But did anybody have any questions on that modeling? Johanna, I see your hand.
Yeah, just a comment, kind of clarification for the group. It looks like projected enrollees is member months. So just wanted to confirm that for folks.
Oh, yeah, good point. Yeah, that's definitely member months, not members. Divide all those by 12 to actually get members. Yeah, thanks for that clarification, Johanna. All right, I don't see any other hands. That's all I was going to go through. I don't know if anybody else had any other high-level questions or comments, or wanted me to go into the Excel document and dig into the nitty-gritty detail.
Just wanted to say thanks for the detailed work you've done here and the time you've taken to go through it like this. Appreciate it.
Yeah, no problem. And I think, you know, once we get the updated results on the undocumented population, where we've revised the assumptions to be more consistent with the Medicaid side, we'll also update the Excel file to publish those. It should mainly affect the enrollment component of the projections. But yeah, we you know, it's underway. It should hopefully be done next week or the week after. But we'll get the updated modeling results out there, since you know that is currently underway.
Oh, that's great. So if we don't have any more questions or comments, I think we'll probably then wrap it up for today. And then the next part of our journey is that the working group is already very actively at work, putting together an initial draft. So we will, you know, continue to work on that as the internal working group. And when we have a draft that's ready for prime time, I'm not going to project timeframes right now because there's so much going on. But certainly, I would say by early October, we should have the ability to bring this group back together. Certainly by mid-October at the latest, for there to be a public stakeholder meeting to talk about that initial draft. So that is the next public step, is for us to expose the initial draft for initial comment, and then have a public stakeholder meeting to walk through that, answer questions, and solicit comments. So I think that probably wraps us up for today. So thank you, Brad. Thank you, Johanna. the two of you in particular for, all of your, really seriously focused work on this, along with Adam and obviously our external actuaries. So, and thanks for everybody for their focus and their participation and your questions. And if something comes up or there are things in the meantime, we are always open to any written comments that, people want to provide. So continue to feel free to send those over to us. All right. Well,
Thank
then I
you.
think you're very welcome. All right. I think we're done for today, and we'll give you an hour and 3 minutes back.
Thanks,
Thank
everyone.
you. Enjoy Nashville, Matt. Bye-bye.